This voiceover concerns itself with the principles of transfusing blood products. Before proceeding, this is an intervention that requires absolutely no mistakes. If a mistake is made and a patient receives a wrong transfusion, it is a sentinel event for the hospital, and I have seen nurses fired almost on the spot for giving it to the wrong patient. So pay attention. We're going to discuss the interventions that the nurse needs to do pre-transfusion. First, you need to verify the doctor's order, inform the patient, and explain the purposes of the procedure. You then have to check for cross-matching and typing to ensure compatibility. You need to obtain and record baseline vital signs and practice strict asepsis. At least 2 licensed registered nurses must check the label of the blood transfusion for the following: the serial number, the blood component, the blood type, the Rh factor, expiration dates, and screening tests for specific diseases such as hepatitis and sexually transmitted diseases. This is to ensure that the blood is free from blood-borne diseases and therefore safe to transfuse. The blood should be at room temperature before the transfusion to prevent chills. You need to identify the client properly. Again, 2 nurses need to check the client's identification. You need to use an 18-gauge needle to allow easy flow of blood. The smallest you can use is a 20-gauge to prevent hemolysis of the red blood cells. You use a blood transfusion set with a special micron mesh filter to prevent administration of blood clots and particles. Sometimes the physician will order Benadryl and acetaminophen to be given before the transfusion to prevent non-hemolytic reactions, especially when you're giving platelets and fresh frozen plasma. Now, this is a chart about the compatibilities. If the donor is type A, recipients that are type A or AB can receive that blood. If the donor is type B, recipients that have type B or type AB can receive the products. If the donor is AB, they can only receive type AB products. If the donor is O, type A can receive it, type B can receive it, type AB can receive it, and type O can receive it. You also must note the Rh compatibility. These are just some pictures of what goes on with blood transfusion. In the top left, you see a vein finder. In the bottom left, you see the infusion catheter that is used, and to the far right is a unit of blood. Now, transfusion responsibilities during the transfusion is to start the infusion slowly at about 10 drops a minute, and you must remain at the bedside for 15 to 30 minutes because this is during the time when adverse reactions usually occur. You need to monitor the vital signs. Altered vital signs indicate adverse reaction, increases in temp, and increases in respiratory rate. Do not mix medications with blood transfusion to prevent adverse effects. Do not incorporate medication into the blood transfusion. Do not use blood transfusion lines for IV push of medications. The only IV fluid you can use with, during, or after a blood transfusion is 0.9 normal saline. Never administer IV fluids with dextrose. dextrose IV fluids can cause hemolysis. You want to administer the blood transfusion for 4 hours, and that's whole blood and packed RBCs. We're going to talk about them in a minute. For plasma, platelets, cryoprecipitate, you need to transfuse them quickly, usually about 20 minutes, because clotting factors in them can be easily destroyed. And you need to observe for potential complications and notify the physicians if there are any. Now this is what a blood transfusion setup will look like. You can see the filter on that blood transfusion set and also the 0.9 normal saline that is piggybacked into it. Now we need to talk a little bit about the components of transfusion therapy. The first is whole blood transfusions, and to tell you the truth, in all my years of nursing, I've never given whole blood. It is generally indicated only for patients who need both increased oxygen carrying capacity and restoration of blood volume when there is no time to prepare or obtain the specific blood components needed. Packed RBCs, and that's what I'm most familiar with, should be transfused over 2 to 3 hours. If the patient cannot tolerate the volume over a maximum of 4 hours, it may be necessary for the blood bank to divide a unit into smaller volumes, providing proper refrigeration of the remaining blood until needed. Now this usually happens with patients who have cardiovascular disease and can't tolerate all that fluid all at once. One unit of packed red blood cells should raise the hemoglobin approximately 1% and the hematocrit about 3%. Platelets need to be administered as rapidly as tolerated, usually 4 units every 30 to 60 minutes. Each unit of platelet should raise the recipient's platelet count by 6,000 to 10,000. However, poor incremental increases occur with alloimmunization from previous transfusions, bleeding, fever, infection, autoimmune destruction, and hypertension. Granulocytes may be beneficial in selected populations of infected, severely granulocytopenic patients, less than 500, not responding to antibiotic therapy and who are expected to experience prolonged suppressed granulocyte production. Usually these are people with that have had really high doses of chemo. Plasma. Because plasma carries the risk of hepatitis equal to that of whole blood, if only volume expansion is required, other colloids, for example albumin, or electrolyte solutions such as Ringer's lactate are preferred. Fresh frozen plasma should be administered as rapidly as tolerated because coagulation factors become unstable after thawing. Albumin is indicated to expand blood volume in patients in hypovolemic shock and to elevate the level of circulating albumin in patients with hypoalbuminemia. The large protein molecule is a major contributor to plasma oncotic pressure. Now we're going to look at some of the acute transfusion reactions. There are allergic reactions, which is caused by sensitivity to plasma proteins of the donor antibody, which reacts with the recipient antigen. You want to assess for flushing, rash, hives, itching, laryngeal edema, and difficulty breathing. There's febrile, non-hemolytic reactions, and this is caused by hypersensitivity to donor white cells, platelets, or plasma proteins. This is the most symptomatic complication of blood transfusions. You assess for sudden chills and fever, flushing, headache, and anxiety. Now there's a septic reaction, and that is caused by transfusion of blood or components contaminated with bacteria. You want to assess for rapid onset of chills, vomiting, marked hypotension, and high fever. Circulatory overload is caused by administrations of blood volume at a rate greater than the circulatory system can accommodate. You want to assess for a rise in venous pressure, dyspnea, crackles or rales, distended neck veins, cough, and elevated blood pressure. Now, hemolytic reactions are probably the most serious. It is caused by the infusion of incompatible blood products. You assess for low back pain, and that's the first sign. This is due to the inflammatory response of the kidneys to incompatible blood. Chills, a feeling of fullness, tachycardia, flushing, tachypnea, hypotension, bleeding, vascular collapse, and acute renal failure. So, what do you do if you have a reaction? First thing, if it occurs, stop the transfusion. And you're going to start a separate line of 0.9 normal saline because you don't want to push through the rest of the blood that's causing the reaction to get a clear line. You place the client in Fowler's position if they're short of breath and administer oxygen. You must remain with the patient, observing signs and symptoms and monitoring vital signs as often as every 5 minutes, and have somebody notify the physician immediately. You prepare to administer emergency drugs such as antihistamines, vasopressors, fluids, and steroids as per the physician's order or protocol. You obtain a urine specimen and send it to the laboratory, to determine the presence of hemoglobin as a result of red blood cell hemolysis. The blood container, blood tubing, attached label, and transfusion record are saved and returned to the laboratory for analysis. Treatment for the hemolytic reaction is directed at correcting hypertension, disseminated intravascular coagulation, and renal failure associated with red blood cell hemolysis and hemoglobinuria. Febrile, non-hemolytic transfusion reactions are treated symptomatically with antipyretics, leukocyte-4 blood products that may be recommended for subsequent transfusions. In septic reaction, you treat the septicemia with antibiotics, increased hydration, steroids, and vasopressors, and intervene for allergic reaction by administering antihistamines, steroids, and epinephrine as indicated by the severity of the reaction. If hives are the only manifestation, transfusion can sometimes be continued, but at a slower rate. For circulatory overload, immediate treatment includes positioning the patient in an upright with feet-dependent diuretics, oxygen, and aminophylline. In the end, you can help prevent transfusion reactions by doing the following: meticulously verifying patient identification, beginning with a type and cross-match sample collection, and labeling and double-checking blood products and the patient identification prior to transfusion. Very important. You inspect the blood product for any gas bubbles or abnormal color before administration. Begin the transfusion slowly and observe the patient closely, particularly during that first 15 minutes. Transfuse the blood within 4 hours, and you change the blood tubing every 4 hours to minimize the risk of bacterial growth at warm room temperatures. You prevent infectious disease transmission through careful donor screening or making sure that the pre-tests are available to identify selected infectious agents. And finally, you prevent hypothermia by assuring that the blood is at least room temperature before transfusion.